Gold therapy, one of the earliest disease-modifying anti-rheumatic drugs, DMARDs, played a significant role in the treatment of rheumatoid arthritis, RA, for much of the 20th century. However, its use has dramatically declined in the 21st century due to the advent of more effective and safer therapies. Below is a detailed account of its history, mechanism, clinical use, and eventual decline. History of gold therapy in rheumatology. 1. Early observations, 19th century. The medicinal use of gold dates back to ancient times, but its role in rheumatology began in the late 19th and early 20th centuries. In 1890, Robert Koch discovered that gold compounds inhibited the growth Mycobacterium tuberculosis. This led to their trial in tuberculosis and later in RA. 2. Introduction in rheumatoid arthritis, 1920s to 1930s. French physician Jacques Forestier first introduced gold salts for RA treatment in the 1920s. He observed that gold injections reduced inflammation and improved joint function in RA patients. 3. Peak use, 1950s to 1980s. Gold compounds, such as gold sodium thiomalate injectable and auranofin oral form introduced in 1985, became standard treatments for RA. They were classified as slow-acting DMARDs and required months of use before benefits appeared. Regular monitoring was required due to potential side effects. Mechanism of action. Gold therapy's exact mechanism remains unclear, but it is believed to exert its effects through immunomodulation, inhibiting macrophage activity and reducing cytokine production, e.g. TNF-α, IL-1, lysosomal stabilization, reducing the release of inflammatory enzymes, T-cell function suppression, decreasing autoimmunity in RA, inhibition of oxidative stress, preventing cellular damage in inflamed joints. Clinical use and administration. 1. Parenteral gold injectable, gold sodium thiomalate, myocrosine, and orothioglucose were the most common injectable forms. Given intramuscularly on a weekly basis initially, then spaced out based on response. Effects typically seen after 3 to 6 months. 2. Oral gold, auranofin, introduced in the 1980s as a more convenient alternative, less effective than injectable forms but had fewer severe side effects. Adverse effects and limitations. Despite its benefits, gold therapy had significant toxicity, including mucocutaneous reactions, stomatitis, rashes, nephrotoxicity, membranous nephropathy, proteinuria, hematologic toxicity, thrombocytopenia, leukopenia, aplastic anemia, gastrointestinal upset, especially with auranofin, peripheral neuropathy. Due to these side effects, regular monitoring of renal function, blood counts, and skin mucosal reactions was necessary. Decline and fate. 1. Emergence of methotrexate, MTX, 1980s to 1990s. Methotrexate, introduced as a DMARD in the 1980s, proved more effective, better tolerated, and easier to monitor than gold. MTX rapidly became the first-line treatment for RA, leading to a decline in gold use. 2. Introduction of biologics, late 1990s, 2000s. TNF inhibitors, e.g. infliximab, etanercept, and other biologics revolutionized RA management. These drugs provided superior efficacy with more targeted immunomodulation. 3. Discontinuation of gold therapy, 2000s present. By the early 2000s, gold compounds were rarely used. Many manufacturers discontinued production due to low demand. Some regions still allowed their use, but they became obsolete in major treatment guidelines. Current status of gold therapy. Virtually abandoned in modern rheumatology. No longer included in major RA treatment guidelines. Still available in rare cases, but replaced by more effective and safer options. Conclusion. Gold therapy was a pioneering DMARD that played a crucial role in RA treatment for decades. However, its slow onset, toxicity, and the arrival of superior therapies like methotrexate and biologics led to its demise. Today, it is a historical footnote rather than a viable treatment option. Gold therapy beyond rheumatology, its role in other indications. Although gold compounds have largely disappeared from rheumatology, research has explored their potential in oncology, infectious diseases, and other conditions. Here's an overview of their historical and current roles in medicine. 1. Oncology. Gold compounds in cancer therapy. Gold-based compounds have been investigated for anti-cancer properties due to their ability to interfere with cell signaling, apoptosis, and oxidative stress. Mechanism of action in cancer treatment: inhibition of thioredoxin reductase, TRXR. Gold compounds target TRXR, a key enzyme in cellular redox balance that is often overactive in cancer cells. Induction of apoptosis: by disrupting mitochondrial function, gold complexes can trigger programmed cell death. Anti-angiogenesis: gold compounds may prevent tumor blood vessel formation, starving cancer cells. Gold compounds in cancer research: Oranofen, oral gold DMARD. Originally developed for rheumatoid arthritis, Oranofen has shown anti-tumor effects in preclinical studies. It is being investigated in clinical trials for lung, ovarian, and pancreatic cancers, particularly in combination with other therapies. Gold nanoparticles, ONPs. Modern research has shifted towards gold nanoparticles as potential targeted drug delivery vehicles in cancer therapy. These nanoparticles can be designed to deliver chemotherapy drugs selectively to tumor cells, reducing toxicity to healthy tissues. Photothermal therapy, PTT, AUNPs absorb light and convert it into heat, which selectively destroys cancer cells. Current status in oncology: Oranofen has entered clinical trials for certain cancers but is not yet a standard treatment. Gold nanoparticles are in experimental stages with promising applications in targeted therapy and drug delivery. 2. Infectious diseases: gold's role in antimicrobial therapy. Tuberculosis, TB. Inspired by Robert Koch's early findings, gold-based compounds have been tested against drug-resistant TB strains. Oranofen has shown activity against Mycobacterium tuberculosis by disrupting redox homeostasis in the bacteria. HIV and viral infections: some gold complexes have demonstrated anti-HIV properties by inhibiting viral enzymes, though clinical applications remain limited. Parasitic infections: Oranofen has shown efficacy against Entamoeba histolytica, the parasite causing amoebiasis, and Plasmodium species, malaria. It is being explored as an anti-parasitic drug in neglected tropical diseases. 3. Neurological disorders. Gold compounds have been studied for neurodegenerative diseases like Alzheimer's disease due to their ability to reduce oxidative stress and amyloid plaque formation. However, clinical success has been limited. 4. Dermatology. Gold compounds were historically used for lichen planus and pemphigus, though they are rarely used today due to better alternatives. Conclusion: is gold therapy still relevant? While gold therapy has vanished from rheumatology, it remains an active area of research in oncology, infectious diseases, and nanomedicine. Oranofen is being repurposed for cancer and infectious diseases. Gold nanoparticles hold promise for targeted drug delivery and photothermal therapy in oncology. Although gold is no longer a mainstream treatment, its chemical properties continue to inspire modern medical innovations. At long-term safety concerns of gold therapy. Gold therapy, primarily in the form of gold salts, injectable gold sodium thiomalate, orothioglucose, and Oranofen, oral gold, has been associated with several long-term safety concerns. These adverse effects contributed to its decline in rheumatology and limited its broader application in medicine. 1. Renal toxicity, gold nephropathy, membranous nephropathy. One of the most serious long-term effects of gold therapy is membranous nephropathy, leading to proteinuria and nephrotic syndrome. This immune-mediated kidney damage occurs due to gold-induced autoantibody formation, similar to other drug-induced renal diseases. Gold nephropathy is usually reversible upon discontinuation, but severe cases can lead to chronic kidney disease, CKD. Tubulointerstitial nephritis, less common but can contribute to progressive renal dysfunction over time. Long-term risk: requires regular urine protein monitoring during therapy. Patients with pre-existing renal disease or diabetes are at higher risk. 2. Hematologic toxicity. Thrombocytopenia. Immune-mediated thrombocytopenia is a severe complication of long-term gold therapy, increasing bleeding risks. Some cases can be life-threatening if not detected early. Aplastic anemia, a rare but fatal side effect where gold suppresses bone marrow function, leading to pancytopenia, often irreversible, and requires urgent discontinuation. Agranulocytosis. Severe neutropenia can predispose patients to fatal infections. Long-term therapy requires routine CBC monitoring. Dermatologic and mucosal toxicity. Gold dermatitis, a chronic lichenoid skin reaction, can develop with long-term use. Exfoliative dermatitis has also been reported in rare cases. Stomatitis, oral ulcers, and gingivitis are common with prolonged exposure to gold compounds. 4. Pulmonary toxicity. Interstitial lung disease, ILD. Chronic gold exposure can lead to fibrotic lung disease, resembling idiopathic pulmonary fibrosis. Symptoms include progressive dyspnea and interstitial infiltrates on imaging. ILD caused by gold therapy is often irreversible. 5. Neurological toxicity. Peripheral neuropathy. Long-term gold therapy has been linked to sensory neuropathy, leading to paresthesia, weakness, and motor dysfunction. May be dose-dependent and can persist even after stopping the drug. Encephalopathy. Rare cases of cognitive impairment, memory loss, and confusion have been reported. Mechanism unclear, but possibly linked to gold accumulation in neural tissues. 6. Gastrointestinal toxicity, auranophin specific. Chronic diarrhea is common with auranophin, limiting its long-term tolerability. Liver enzyme elevation may occur, requiring hepatic function monitoring. 7. Immunological concerns and autoimmune reactions. Autoantibody formation. Gold therapy has been linked to autoimmune diseases like drug-induced lupus with ANA and anti-dsDNA positivity. Gold-related vasculitis is a rare but severe long-term complication. Conclusion. Long-term risks outweigh benefits. Due to these serious long-term toxicities, gold therapy fell out of favor once safer and more effective DMARDs, like methotrexate and biologics, became available. Regular monitoring, renal function, blood counts, pulmonary exams, was mandatory, making its long-term use impractical. Gold compounds are now obsolete in rheumatology and have limited use in modern medicine except for experimental cancer and infectious disease treatments.